Hi everybody, my name's Lily Brown.
Youth. Sorry.
Oh. So I work in the Center for the Treatment and Study of Anxiety, which is directed by Dr. Edna Foa, who wished that she could be here today and unfortunately had conflicting appointments. So I'm here really to present on her legacy of research and the forward progress that she's kind of headed in terms of future research studies that we are currently conducting and that we hope to conduct in the near future. So just to provide an overview of what I hope to discuss today, I'll be just briefly touching on an overview of what is prolonged exposure, which is a therapy that Dr. Edna Foa has developed, as well as empirical evidence suggesting that prolonged exposure is helpful in reducing symptoms of post-traumatic stress disorder. But the majority of what I'll be discussing will be kind of more recent research about incorporating prolonged exposure in comorbid conditions, as well as dissemination efforts at getting this treatment out into the community. And finally, as I mentioned, touching briefly on future directions. So post-traumatic stress disorder, or PTSD, as I'll refer to it here, many of you are already familiar with this disorder, but it develops following exposure to a trauma, which can include actual or threatened death, physical injury, or sexual violations that an individual has either directly experienced, witnessed, or learned about, that occurs in about 60 to 70% of people in terms of traumatic exposure. But the development of PTSD only occurs in about 7% of those who experience trauma. Those who do experience PTSD have a number of symptoms that go along with this disorder, including feeling like you're aroused more frequently than other people, like you have a heightened startle response, avoiding triggers that might make you anxious, and other related symptoms. Unfortunately, though, PTSD doesn't occur in a vacuum. So what I'll be talking about first is the cost and burden of this disorder. It's a highly comorbid condition with other important psychiatric conditions, meaning people with PTSD commonly also have mood disorders like depression, also a variety of other anxiety disorders and substance use disorders for both men and females. So this is not the kind of syndrome that occurs in a vacuum. It also is associated with enhanced medical comorbidities across a wide variety of medical conditions that I've included here. So people with PTSD are more likely to have these medical conditions compared to people without this diagnosis. And selfishly, I want to mention this point in particular about suicidal thoughts and behaviors in folks with PTSD. This is actually my area of research. What we know is that people with PTSD are significantly more likely to think about suicide than people without PTSD. And in the past year, they're more likely to have actually made a suicide attempt than people without PTSD. That's really important because suicide attempts are relatively low frequency events, and yet having this disorder makes it significantly more likely that someone might go on to make a suicide attempt. So it's really an important condition to study further. So what do we know about effective treatments for PTSD? Well, there are a number of empirically supported treatments that have demonstrated success in reducing symptoms of PTSD. CBT in particular is the standard recommendation of treatments. Prolonged exposure is one form of cognitive behavioral therapy, but other medications are also known to be efficacious in helping people with PTSD. I'll be presenting some data on that as we go through as well. Prolonged exposure, as I mentioned, is the therapy that Dr. Edna Foa has developed. It has the largest number of studies supporting its efficacy and effectiveness. So not only how well does it work in this trial that's tightly controlled, but how well does it work when we actually implement it in the community, in the real world, if you will. It's also been shown to be effective with the widest range of PTSD populations. I'll show you some data on that as well. And it's been studied across multiple independent centers, both in the US and outside of the US. Prolonged exposure involves two primary procedures. The first is helping people to reduce avoidance of people, places, or objects that they've been avoiding because of the anxiety that's followed from their traumatic experience. This might include certain people that remind them of an assailant, or places that, for whatever reason, bring up memory of the trauma. It's a big part of treatment, is helping people to identify objectively safe situations that they can work toward incorporating more approach toward them in their daily lives. And the second component is imaginal exposure. Now, what this means is it's helping people over time, with the support of a therapist, to actually recount the traumatic experience in a lot of detail. And again, it's repeated over multiple therapy sessions and multiple times within a therapy session. The point of this is that many people with PTSD do a lot to avoid thinking about the trauma. And yet, despite their best efforts, the memory remains, and it's very anxiety-provoking. So the focus of the prolonged exposure is helping people to process the trauma and their memory of the trauma, coupled with techniques aimed at changing how the person views themselves and the world, and their ability to cope with anxiety related to the trauma. So both imaginal exposure and processing are the second biggest component of prolonged exposure. There have been a number of studies showing that prolonged exposure-based therapies, actually more broadly speaking, are effective in reducing both chronic cases of PTSD, those lasting longer than 3 months, and more acute cases of PTSD. And in 2008, an Institute of Medicine report came out and officially said that exposure-based therapies are kind of recommended for the treatment of PTSD. But what about in cases where PTSD isn't occurring in a vacuum? As I showed you on one of my first slides, commonly individuals with this disorder also have other conditions that go along with it. How does this treatment work in these more complex and yet common conditions? First, I'll show you some data on individuals who have PTSD and also a co-occurring personality disorder, so difficulties with relationships or with regulating emotions more broadly speaking, or other things that go along with what we call a personality disorder. Does PTSD work for people who have this? Well, in brief, we found that it does. So if we compare individuals with a personality disorder and without a personality disorder, PTSD symptom reduction is comparable between the two conditions, and both conditions experience significant reductions in PTSD symptoms in relationship to their treatment. There's also no difference in terms of depression symptoms. Both people with and without personality disorders experience significant benefit in terms of depression symptoms in response to treatment. There's no differences between these two groups. So this is exciting, and it suggests that not only are these pure cases of PTSD responsive to prolonged exposure, but also some evidence that more complicated cases also respond well to this treatment. How about in depression? As I mentioned, depression is a common co-occurring disorder with PTSD. It's not a stretch of the imagination that someone who's experienced a trauma might experience things like low mood and sadness and feeling hopeless. So you might imagine that it's important for us to know, how do these folks respond to this treatment? This study compared individuals with a current episode of depression to people with a history of depression but no current depression, and a third group here who had no history or current depression. What we found were comparable reductions in PTSD symptoms, both from pre to post treatment, and if we follow people even after they've completed the treatment. All three groups experienced significant reductions in PTSD symptoms, regardless of whether they've ever had depression or currently have depression. So that's exciting, and it demonstrates again that this is a treatment that can be helpful even for individuals who have depression on top of their PTSD symptoms. How about for individuals who are high on anger? There have been some clinical reports and theoretical models that suggest maybe people who are higher in anger are less likely to respond to this type of treatment for a variety of reasons. So we tested this out, and we found that if we compare individuals who are higher in anger, which is that green line, to people who are lower in anger, there's no difference in terms of how well their PTSD symptoms reduced in response to PTSD treatment. This is really important. We also found that individuals who start treatment high on this rating of anger experience significant reductions in anger itself over the course of treatment. So not only is prolonged exposure effective at reducing PTSD symptoms, but it also seems to help with some other related symptoms as well, even if it's not the direct target of the treatment. How about, does treatment effect depend on the type of trauma that one's experienced? You might imagine that this would be the case. And so some research has also tested this. What if we take, for instance, individuals who've been physically assaulted compared to adults who've been survivors of rape or childhood sexual abuse? Are there differences in treatment outcome between these three conditions? Fortunately, we have found that there were not. Again, both in terms of changes from the beginning to the end of treatment and at a later time point. What about substance use disorders? Here we've compared prolonged exposure plus supportive counseling for substance use disorders, in this case it was alcohol use disorder, compared to supportive counseling alone without prolonged exposure. And we also included a medication that's been known to be effective in helping with alcohol use disorders, naltrexone, compared to a placebo. So people were in one of these four conditions that we outlined here. Here we're interested in measuring how do these treatments affect percentage of days drinking. We found significant reductions in all four conditions in terms of percentage of days drinking over the course of treatment. And after we took away the treatment, the completed treatment, we looked at relapse rates and found that individuals who were taking naltrexone and who had PE in addition to substance-focused counseling had less relapse in terms of days drinking compared to the other conditions. There's been another study that compared individuals with borderline personality disorder, which is usually a high-risk condition that involves non-suicidal self-injury or suicide attempts, coupled with problems in managing relationships and other features that go along with it. How do individuals with borderline personality disorder and PTSD respond to treatment? Well, a group of researchers at the University of Washington collaborated with Edna to try to address this question and found that those in this combined treatment that's focused on borderline personality disorder and PE had significantly fewer, the combined condition had significantly greater chances of having remitted from PTSD, so no longer meeting criteria for PTSD by the end of treatment, compared to those who were just getting treatment for their borderline personality disorder. And those gains were maintained at follow-up in this combined condition, whereas those who only received treatment for borderline personality disorder were no longer in a state of remission 3 months after treatment. So this is suggesting the power of potentially combining focused treatments on PTSD and other comorbid conditions in terms of maintaining gains even after the treatment's already done. This is a really important area of research. What about if we look at actual suicide behaviors? Again, selfishly, this is my area of research and something that I'm really interested in. So if we look at actual suicide attempts, these folks who were in the combined condition had significantly fewer suicide attempts compared to those who were not receiving prolonged exposure. And they also were significantly less likely to do anything else to hurt themselves without the intention of dying compared to those who did not get prolonged exposure. We've seen a few presentations already on psychosis and how best to treat psychosis. How do individuals with psychosis respond to prolonged exposure? This is a small sample, but it's a promising one, where prolonged exposure was compared to a waitlist condition for individuals with PTSD and psychosis. And what we found was that not only were there significantly greater reductions in PTSD symptoms in those in the active treatment condition and prolonged exposure, but those gains were maintained, again, after treatment was taken away. This is really important suggesting that people who have psychosis are potentially just as well suited for receiving this treatment compared to people who don't. In this same study, individuals who were in the prolonged exposure condition were also significantly less likely by the end of treatment to actually meet criteria for the disorder compared to those who were in the waitlist condition. So in summary so far, I've given you a lot of data. The reason for that is I really want to drive home the important point, which is that up till this point, or up until recently, we've known that prolonged exposure works for treating trauma. We've been less confident about how other comorbid conditions respond to prolonged exposure. Now we're finding this emerging database and base of literature suggesting that individuals with depression or borderline personality or other personality disorders, individuals with anger or substance use disorders or psychosis seem to also be receiving benefit from this treatment, which is helpful from the standpoint of helping clinicians trying to figure out, what do I do with these more complex people who I'm seeing in my office? So a treatment that is effective if it's only being delivered by kind of the inventor of the treatment or the center that the inventor directs isn't particularly helpful. What we've been working on a lot in recent years in the center is trying to look at dissemination efforts, meaning how do we get this treatment out in the front lines? How do we get this treatment in the hands of community clinicians and people in the VA to help the most people possible so that it's not just our center over at the University of Pennsylvania who's providing this treatment, especially since there's a lot of evidence that it works. So in one study that Dr. Foa led, we compared clinicians in our center to community clinicians in terms of how well did they do at delivering this treatment, and importantly, how well did their patients do? Were there differences in response rates based on whether you were getting treated by an expert at our center compared to a community mental health clinician? There weren't. And this is really important, and it's suggesting that community mental health providers are just as good at doing this as we are, especially if after they've been trained in how to do it. This is really good news for us. The findings on terms of patient depression were also similar between those in the community and those through our center. Many of you may know that in the VA, there's been a large-scale push to roll out empirically supported treatments for a variety of conditions. Prolonged exposure is one of the treatments that's being rolled out. And since that initiative has begun, over 2,000 clinicians have been trained in this procedure in the VA. Over 70 are trained as consultants, and 16 are certified to provide training themselves in this kind of treatment. And because there's been such a push toward training clinicians in how to do this in the VA, we've been able to look at data in terms of how veterans are responding to this in the VA system. We're finding large effect sizes in terms of changes from pre to post treatment in veterans receiving this treatment. Again, suggesting that not only in these tightly controlled studies do we find benefits of this treatment, but also when we go out into the real world, when we apply this treatment to veterans, it's also working. So far, kind of in summary, there's a number of empirically supported treatments for PTSD. Prolonged exposure has the most evidence across a wide variety of types of trauma and types of populations, as well as comorbid conditions. There's also now emerging evidence to suggest that even more complicated examples of trauma and PTSD respond well to prolonged exposure, which is really an exciting finding if we're thinking about how best to help people who've been exposed to a traumatic situation and have distress related to that. PE can be successfully disseminated to community clinicians, both in community mental health centers and in the VA population. And we've also done some studies where we're looking at dissemination over long distances and finding that there is no difference in terms of integrating this treatment model, even over supervising long distances and kind of cross-cultural incorporations of this treatment. So what's next for our team? We're doing a few studies right now in collaboration with the Department of Defense and active duty military personnel, testing out a couple of important research questions. The first is, what do we do about the timing of treatment delivery? If we have a group of patients who can only come in for a short amount of time, are they more likely to respond, less likely, or do they respond in the same way as people who can spread their treatment out over long times? This is a study that we just got our data in maybe 2 weeks ago, so we're still trying to figure this out, but it's an exciting question because our hypothesis is that there will not be any difference in outcome based on the timing of session delivery, meaning we suspect, even in this masked format where you get the same amount of sessions in less time, that people will respond well. I know we're almost out of time, so just quickly, we're also comparing 60-minute sessions to 90-minute sessions. As many of you know, prolonged exposure is usually implemented in 90-minute sessions, which for some community workers in particular isn't possible to incorporate into clinical practice. So we're also studying this in the Department of Defense now to try to see whether the duration of session actually affects outcome. What's the best way to train clinicians? We're studying this in the Department of Defense now too. Is a workshop enough to help clinicians feel comfortable in incorporating this treatment, or do they need additional supervision and consultation following the workshop? This is an important question for building our dissemination efforts as well. What are the mechanisms of change? So it's important to know that prolonged exposure works, but we also need to know why and how it works. There's some research that we're doing to answer this as well. And finally, we're interested in tackling other comorbid conditions that we haven't presented here to try to get a sense really again of how does this treatment model affect the most complex presentations of people who've experienced trauma. So I know that was a lot of information. If anybody has any questions, feel free to send me an email, and I appreciate your time.